All right, the time is now 12:01. I would like to welcome everyone and thank you all so much for joining us today for this Public Health Discovery Seminar series. My name is Caitlin Magruder, and I'm an admissions counselor here at the Celia Scott Weatherhead School of Public Health and Tropical Medicine. And today I have with me Melissa Rosenthal, one of our PhD candidates in the Department of International Health and Sustainable Development. And today she will be talking to us about opioid use disorder in the current international policy landscape, a social listening study. Just some really quick housekeeping rules before we get started. Um, if you have any questions while Melissa is presenting, please drop them either in the chat or the Q&A, and we will address them all at the very end. We'll have about a 10-minute Q&A session if you have any questions about what she's presenting today. All right, thank you all so much for joining us, and I will now hand it off to Melissa.
Wonderful. Thank you very much. It's an absolute pleasure to be with you all today. As was said, Melissa Rosenthal, I'm a second-year PhD student here at the Celia Scott Weatherhead School. And my research interest, I like to say, focuses at the nexus of utilizing technology and technological approaches to address health system strengthening, both here domestically as well as internationally. And today I will be sharing with you some preliminary findings of an ongoing study that I'm working on with my advisor, Dr. Jana Wisniewski, called, as I said in the introduction, Opioid Use Disorder in the Current International Policy Landscape. And before we get into the methods of the study and the study purpose, I want to make sure that we're all on the same page when it comes to a few common acronyms and terms that I will be referring to throughout this presentation. Firstly, I will be talking about opioid use disorder, or OUD, and specifically, we will be talking about changes in some regulations of opioid treatment providers, or OTPs. We will be speaking specifically about regulation changes when it comes to dispensing treatments for opioid use disorder, or MOUDs. And commonly, this is an umbrella term that encompasses any sort of pharmacological intervention to treat OUD. Commonly, we think of opioid antagonist treatments like methadone, buprenorphine, or Suboxone. However, there are many types of treatments that fall under this umbrella. I will also be discussing MAT interchangeably with MOUD, essentially same thing, just another umbrella term to encompass those treatments. I will be speaking specifically about a change in a regulation here in the US by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Essentially, they are the governing body for any sort of protocols or practices and guidelines that comes to treating substance use disorders here in the US. Specifically, we'll be focusing on changes in the 42 CFR Part 8, which is a US federal regulation governing opioid treatment programs here in the States. Now that we got that out of the way, we know that substance use disorder is a pervasive issue worldwide. Approximately 39.5 million are diagnosed with drug use disorders globally, and we see approximately 600,000 deaths attributed to drug use annually. And it's notable that of these 600,000, 80% are opioid related, both encompassing overdoses as well as other secondary causes related to opioid use disorder. Thinking of vehicular accidents or any sort of other deaths that are related to having opioid use disorder and other impairments related to that. So that's where we're seeing that 25 versus the distinction with that 80% that I have in this figure here. So given that this is quite a pervasive issue, what is the standard of care? Currently, as I mentioned in the first slide, or the second slide, MOUD is that standard of care. They're seeing an association between MOUD and decreased overdose throughout the literature. And we've seen other successes as well, including reduced emergency department visits and other classic successes when it comes to health services research. It's notable that these MOUDs are traditionally dispensed in clinic via weekly supervised visits. So what does that mean? Essentially, if you received an OUD diagnosis, you would report to your provider, and somebody in the clinic would dispense you your dosage and physically watch you take said dosage. As you can imagine, there are many barriers to receiving care in clinic. Commonly, we think of issues in access. So having a facility that dispenses MOUD in your community, as well as having the financial means to travel if you don't have those facilities nearby. It's also worth noting that even if you do have the financial resources to travel, scheduling frequent appointments interferes with or can interfere with other obligations that are essential to one's livelihood, thinking of professional obligations and family obligations. So in order to mitigate some of these issues, there's been a rising support for including take-home dosages as a mechanism to combat some of those access issues. Specifically, this has been seen in many other countries since the 1970s in some way or another. There's been quite a range of successes as a result of take-home MOUD, including a decrease in emergency department visits, as well as an overall decrease in mortality related to opioid overdoses. There's also been a decrease in hospital admissions as a result of this take-home infrastructure. While this all sounds well and good, there are some valid controversies related to take-home MOUD. And since these drugs are opioids themselves, there is quite a bit of concern related to having detrimental medication errors. It's worth noting that MOUDs often revolve around having a tapered dosage over time. So you may start out with a larger dosage at week 3, and then at week 4, you're taking a slightly lower dosage, and so on and so forth. And as a result, it's easy to mix up your dosages from week to week, from day to day. In addition, you also run the risk of individuals selling their excess dosages. You also have, by nature of having a take-home infrastructure, you're not visiting your provider as often as an in-clinic dosage visit. So as a result, providers aren't seeing how individuals are tolerating their dosages. Are there any adverse events? Are there any ways to improve one's protocol? That's not being seen at this point. Also, even if there's lax eligibility criteria when it comes to who actually can access take-home MOUD. While every country that utilizes this take-home MOUD infrastructure defines who's eligible a little bit differently. They all use the term stability. However, what's stable in one context versus stable in another could be totally different. For instance, some countries describe stable as so many days post-withdrawal. Some countries describe stability at the discretion of one's provider, and there's everything in between from that as well. So how the US viewed this process before COVID-19 was as followed. The US required a 90-day in-person delivery before one was eligible for supplementary unsupervised dosages. So what does that mean? You would receive the bulk of your treatment the first 90 days in person during those supervised dosages, and you would receive a few supplementary take-home dosages to help you taper off of your treatment. However, this was also contingent on having no criminal history and being able to submit to random drug tests approximately 8 times per year. It's also notable that this infrastructure did not apply to methadone at the time. And as we know, as a result of the pandemic, there were quite a few policy changes related to relaxing some regulations for in-person care delivery. And we've seen that with take-home MOUD as well. In March of 2020, there were updates to that statute that I mentioned in the acronym slide, 42 CFR Part 8, which essentially was a blanket exemption to provide short-term take-home MOUD for all patients that were prescribed an MOUD at the time. And this policy actually is still in place today. It required a maximum of a 28-day dosage for patients, again, that were quote unquote stable, as well as a maximum of 14-day dosages for less stable patients. And how this would typically work is, again, you would follow a staggered protocol. So in the first 2 weeks of treatment, one would receive a week's dosage at a time. Then starting at day 15, all the way through day 30, individuals would then start receiving 14-day supplies. And then from day 31 onward, 28-day supplies until you would run your course of treatment there. It's also notable that there were requirements for follow-up to ensure that individuals were utilizing these treatments in the proper manner and that you actually saw improvement at treatment initiation. Also, it's notable that in the US, patients must receive dosages from an opioid treatment provider, and they can't receive dosages from community pharmacies. How does this look internationally? Currently, 18 countries allow take-home MOUD. It is notable that these countries are primarily high-income countries in the West, with the exception of Vietnam also allows a take-home protocol. So as a result, analyzing the impact of a take-home infrastructure across countries of varying income status isn't possible at this point. It's also notable that regulation can be at many levels of government and differ from country to country. Normally, it's either at the national or provincial level. Some countries do this at the state level. Canada does this by province, the UK nationally, Australia by the state. And there's been ranges of dosages from anywhere from 4 dosages per week all the way up to 90 dosages per week. Australia, as you can see here, you have to have a maximum of 4 dosages per week. The UK, no more than 7 per week. Canada, 7 days dosages, which are then used to determine one stability, and then the provider can determine dosage rates tailored to each individual patient. So there are many gaps in the literature. I've mentioned several studies that were examining the impact of take-home MOUD through looking at a few key indicators, namely emergency department usages and other mortality indicators such as overdose rates, etc. However, there is very little around the patient perspective. The benefits and drawbacks of take-home MOUD is not really discussed. And there's not a lot of discussion on the delivery mechanism itself. Is it beneficial? What can be improved? And there isn't a lot of discussion surrounding a take-home option, despite this being available in many countries since the 1970s. So this study seeks to answer a couple questions. One, what characterizes attitudes toward patient experience with MOUD? And two, what is the perception of take-home MOUD treatment? And also within that question, we are hoping to find if these perceptions differ in the US compared to countries that have had a longstanding at-home delivery infrastructure. And we sought to answer these questions utilizing social listening. And social listening essentially is a method used to analyze a large range of social media posts to understand what people are thinking in order to create actionable insights or actionable policy and program changes. And the thought process of why we decided to use social listening in the study is you have a large sample of data as opposed to interviews and surveys, and you're able to easily compare things across time. When you're dealing with surveys and interviews, you often rely on an individual's recall, or you have to start your sampling process and continue it over multiple years. Utilizing social listening allows us to get a wide range of data and analyze them over many years in a relatively short period of time in a more retrospective manner. So in terms of how we utilize social listening in this study, we had data from March 2022 all the way to March 2024. So you can see we had a sample of a universe of over 100,000 posts. And we utilized a software called Sprout Social, which scoured the internet over multiple social media types. You can see here I've listed them: Facebook, Instagram, Reddit, as well as YouTube comments, and generated several interesting data points for our analysis. The post text, geolocation, it's worth noting that some posts recognized a geotag, others did not. So we had many entries that we were not able to match with a specific country or region. And we also were able to look at interactions, such as likes, replies, and other comments. We could see the frequency of postings, and we could also see the sentiment of what people were saying. Were people talking about MOUD and take-home MOUD specifically in a positive way or in a negative way? So our search criteria was as followed. We utilized a broad search strategy using many umbrella terms such as drugs and other known street names, as well as more specified terms such as methadone, MOUD, OUD, take home, etc. Many more. I'm happy to answer questions at the end for specific search terms that we used. We also set our search terms to only include English responses, because we were only looking at English-speaking countries. And the reason that we did that was we were looking at countries that had established take-home infrastructures. And we decided on Canada, the UK, Australia, and here the US. And these countries were selected because, as I mentioned earlier in the presentation, these take-home infrastructures are primarily in high-income Western countries. So we felt that this selection was a good representation of the infrastructures that are out there. We also utilized this 2-year time frame to get a real-time understanding of the current viewpoints and to negate any sort of COVID-19 related biases. So once we got our data, we utilized a qualitative approach to analyze our universe of responses. We took a random sample of 660 posts, and we did a combination of inductive and deductive coding, which is standard in qualitative methods. Essentially, we had an idea of some of the buckets or umbrellas that we thought we would find in these data. And we also found new categories when we started getting into the data. So that's what that means. The two of us also did dual coding of 10% of the sample, which is a standard practice for qualitative methods. We had a pretty good agreement. We agreed about 90% of the responses, so that is quite high in terms of qualitative methods. And we found several interesting themes throughout. And I'll take some time now to go through a few of them that we found in this phase of the research. We found quite a bit on state of the problem. So any sort of discussion related to the gravity of OUD and issues of pervasive drug use in one's community. I know 2 people here in my little town in Montana who died from fentanyl overdose last week. It's a horrible problem everywhere. And this post is quite representative of the many that we found talking about the pervasiveness of drug use globally. We also then discussed perceptions of MOUD or MAT. Any sort of discussions from a societal level. So this poster writes, Suboxone has opioid blockers and no street value. It is necessary to get out alive. Due to this medication, I have been treated as an active addict. Addicts are humans with a disease, demonizing us as the scum of the earth. So Suboxone or MAT or MOUD as a necessary evil, but that people that are being treated with these solutions are stigmatized. We also looked specifically at the discussion of MOUD at home, or the take-home aspect of that, and any sort of discussion related to MAT dispense outside of a facility, we've included here. Many shared the availability of said treatments. That was a common theme that we found within this category. We also saw individuals discussing the benefits of having take-home options as a means of access. So this responder is discussing that home-based addiction recovery is the solution to get one's life back on track. And we also looked broadly at weaknesses in the existing treatment system. Any sort of discussion related to difficulties in treatment was included in this category. This responder writes that they were fired from their pain management clinic in April 2019 because they didn't show up for their per contract pill count. So they knew that they were 11 pills short and just didn't show up. So issues in regulations, issues of policies that make it difficult for individuals to comply with treatment and with provider oversight hamper the effectiveness of these treatments themselves. We also found quite a bit of information related to individuals sharing the availability of treatment services, similar to what we saw with the perceptions of at-home take-home MOUD. We've seen something similar here. This responder asks about the process of enrolling in a methadone clinic and goes through how individuals can seek an initial evaluation, get enrolled, and attend their visits to receive their dosages. And then we also found quite a bit of information related to misinformation and spreading information that is not necessarily correct. So this here is a post that originated in the UK discussing that there's only one drug rehab facility for pediatric populations in the UK run by the Church of Scientology. That is factually inaccurate. So that's another example of the pervasive misinformation, disinformation that we're seeing. And I'm sure that those of you who attended other public health discovery series, that's a common theme that we're seeing in public health currently right now. And then interestingly, we found some information on complementary alternative medicine. So discussion of other supplements, non-pharmacologic supplements used to either help with, in tandem with MOUDs or instead of MOUDs. So the two that we saw throughout our analysis were ibogaine and kratom. And some people discuss, the majority of individuals in this universe that we've looked at so far have discussed these treatments in a positive way. This respondent describes the use of kratom to bridge the gap that traditional MOUDs may have, so to help ease withdrawal, as well as to help make the treatment process more palatable. In terms of our findings for this thus far, this again is actually an old slide, but it still brings home the point that we wanted to grasp today. The majority of our respondents of our posts, are based in the US, and we're seeing around the same number of posts from Canada and the UK. I also want to mention that there is a caveat with this. As you can see here, there were, of this sample of 330, there were 109 posts that were either not specified or from countries that we didn't necessarily target in our analysis. For instance, we found several posts that originated from India, and India was not in our search criteria. So it's worth noting that there are flaws when it comes to the mechanism that we used for our social listening, but it's still interesting nonetheless that we are seeing a variety of posts from several different countries here. So in terms of our preliminary findings, we found 18 posts that were describing MAT at home, 27 describing perceptions of MAT, and 2 at the time describing complementary alternative medicine. We've also seen that there were only 166 posts that were relevant to the research question. So it's worth noting that there's a lot of noise in this sample and in the total universe that were not necessarily related to our research questions. However, some key takeaway messages that we did find in our analysis is that when people talk about MOUD, there is a pervasive stigma surrounding these types of treatment. Individuals describe being treated as less than, and other stigmas surrounding accessing as well as just being on these treatments. There's also a lot of misinformation and blaming of politicians for the state of the problem. And as we'll get to this on the next slide here, as we were coming closer to the US election, we've seen more and more of this throughout the sample. There also was an overall positive discussion of take-home MOUD for those that discuss it. While in this original sample, there were very few that described take-home MOUD, the ones that did discussed it positively as something that increased access, that made one's life easier. And as I mentioned, there is little discussion of take-home MOUD in the sample that we used for our first phase. It's also worth highlighting that in terms of time trends, we didn't see anything particularly meaningful. Initially, we thought that we would see a larger acceptance of take-home MOUD as we got further in the sample, that over time people would learn to accept it. However, that's really not the case. As you can see, there's this large jump here, January to March 2024, and we are still investigating why this is the case here. However, everything else is still pretty stagnant in terms of people discussing these topics. It's also worth noting that the engagement period remains pretty unremarkable as we go through it as well. We've seen a lull here in the summer and early fall, but really nothing meaningful in terms of providing any additional insights in our analysis. So in order to combat the limited data that we've seen related to take-home MOUD, we are currently in phase 2 of this analysis, in which we are doing a targeted word search of several key terms that we believe will yield us more results for a richer analysis. We are essentially going through our outputs of these posts that we got from Sprout Social and manually searching these terms throughout and going through our analysis that way. Currently, we're still in the process, and we are utilizing these terms as well as a few others in our analysis. So we're going in specifically targeting more specific terms such as MOUD, the specific drugs themselves like methadone, Suboxone, buprenorphine, looking at home, take home, those terms, as well as going through those complementary alternative medicine sources as well, which include Ibogaine as well as Kratom, which is not listed on this slide. So it's worth noting that since we are still in the process of drawing out that second phase 2 sample, just so we can get an idea of what we are anticipating for this analysis, I've created here a table that simply outlines the number of mentions related to each category. So of the 13 spreadsheets that we have of social media posts from that 2-year period, when we've highlighted the term MOUD in each individual spreadsheet, we had 76 mentions. So that can mean that one post may mention something multiple times, but it's worth noting that we will still get a rather large sample just to give everyone a taste of where we are so far. Currently, I am going through the spreadsheets for the term methadone, and I'm at spreadsheet 10 of 13, and we have approximately 1,000 posts, individual posts from that term alone. So I'm optimistic, I shall say, that we will get a large sample or a large enough sample to delve into more of a meaningful analysis in our second phase. So based on phase 1, we found a few preliminary conclusions that will help guide us into our next phase. We found that there's been an overall positive association with take-home MOUD when discussed, and that despite substantial policy change in the US and a long-term availability in those 3 other countries, the UK, Canada, and Australia, really little discussion related to at-home MAT, at-home MOUD. There really isn't a meaningful difference between countries. Individuals are speaking the same about take-home MOUD in the US versus Canada and these other countries as well. It is worth noting that this foray into social listening was my first my first journey into using this method, as well as my advisors. So we learned several interesting lessons throughout this process, and came up with several avenues for future research that are worth discussing. While we were very intentional with determining our overall time frame sample, it really would be a benefit to have a longer search timeline to understand trends. While we were coming up on the COVID-19 pandemic and saw potential biases by introducing those data, it maybe would have been interesting to expand the search to include maybe 10 years, maybe 5 years, and to see more of these trends. Also, it would be interesting to look at the level of analysis across different platforms. And what I mean by that is, what are people saying in the YouTube comments versus Reddit versus Instagram? Do people have different sentiments related to take-home MOUD or MOUD itself when you're talking about people who are posting on different media? Also, while we did select a few countries in a strategic manner, it would be interesting to look at more countries. Specifically, it would be interesting to look at data from Vietnam as a country that's not part of the West. Perhaps norms and attitudes towards take-home MOUD and MOUD itself may be different in those contexts. We also need more detailed data to understand awareness. While we aimed to seek if individuals were even aware of a take-home option across these contexts, you really need more detailed information to understand that awareness aspect. Thinking of maybe a more targeted survey, maybe more in-depth case studies or interviews. And also, there is definitely an art to building a search criteria. While we were intentional about selecting a broad, overarching umbrella term search strategy by using things like drug, we got a lot of noise in our sample that might not necessarily be of benefit. It's worth noting, as an example, we were seeing a lot of information on treatment, on pain management treatment post-surgery that wasn't necessarily part of our research question. And we also found quite a bit of information on GLP-1 inhibitors that, again, not part of our research question, but still interesting nonetheless. So if you were going to do social listening in the future, I would suggest selecting search terms that are narrower in scope, so that way you are getting more of a targeted universe of data for better analysis and more meaningful public health impact. It's worth noting that these data, while large in scope, do provide a lot of avenues for additional research. Namely, you could do a whole range of discourse analyses of stigma, perceived stigma related to drug use. You could also do an entirely different nuanced examination of alternative care for OUD, specifically looking at kratom and ibogaine and seeing if these more traditional remedies are effective and what patients are saying. And you can do an entire analysis of disinformation and misinformation to analyze as well, related to drug use and just in general. We got a lot of information around disinformation and misinformation of a whole range of public health topics that weren't related to our research question. So that is all I have for my presentation. I'm happy to open it up to questions from the audience or any clarifications that you all have. Thank you very much. It's been a pleasure.
Thank you so much, Melissa, for your wonderful presentation today. As I stated in the very beginning, please, if you have any questions or, like Melissa said, any further clarification is required, please drop those in either the Q&A or the chat at this time, and we will have about 10-15 minutes to go through all of your questions. All right, we have a question. Could you talk more about why Vietnam would be an interesting country to look at?
Sure. Primarily, it would be interesting to see if some of these norms and stigmas related to MOUD and MOUD access differs in a country that's not in the West and that has a different makeup in terms of population than we're seeing in countries that are fairly similar. So that's why I think that would be an interesting case study moving forward.
Thank you for that, Melissa. Any other questions? Well, if we don't have any additional questions, I want to thank you all for attending today. Melissa, I want to thank you so much for your wonderful presentation. If you would like to connect with us or connect with Melissa further, I'm going to drop our SPHTM admissions email address in the chat for everyone, and we can connect you from there. If you have any additional questions that you may not want to ask now, please feel free to do so, and we will get you connected. So I just dropped that email in the chat, and Melissa, you're going to drop yours in the chat as well?
I did. So if anyone has questions specifically for me, I'm always happy to answer or set up a time to chat with anyone.
Excellent. Thank you all so much for joining us today. I will give you the last 22 minutes of this hour back. Thanks again.